Hello from Berlin, and once again, welcome to this week's episode of the Quintessencial Thursdays. Nothing's changed. We're still on lockdown. People are not being able to practice, and we're at home trying to pass the time and wait for this to be over. So I'm very happy today to welcome a lot of you again for this week's session on prosthodontics. Today's webinar will be moderated by Professor Irena Seiler, who's also the editor-in-chief of the IJP and a co-author of an upcoming book together with Vincent Fehmer and Bjarne Petersen later this year. We have the honor of welcoming three of our authors, Dr. Galip Gurel, Dr. Stefan Kubi, and Marcello Calamita. Marcello is writing a book. It will be published probably later this year, maybe next year. The others have books available on our online store. So enjoy tonight's session, learn, educate yourselves, be active, interactive, feel free to ask questions, and stay tuned and stay safe.
So dear colleagues worldwide, wherever you are, I would say good morning, good afternoon, good evening. Welcome to this session. It's really an exciting session. I think the whole initiative is really exciting. We've all been touched by this confinement period now, and some of us are now going slowly back to normal, while others are still locked in. So I think it's still the time to share knowledge this way. And
You have to turn on your camera, I'm sorry.
You told me, okay.
No, I didn't. There you go.
Okay, so I have to start again. Let me start again. Now that you're seeing me, I'm sorry for this little technical glitch. Dear colleagues worldwide, welcome to this wonderful series of webinars that the Quintessence has put up here. The Quintessential Thursdays, it's actually the 5th week that this is happening, and it's not the 5th week of confinement only. It's been going on much longer than this. Some of us are slowly coming back to normality, others are still locked in. And it's a wonderful moment for us to share the know-how and to come closer with all our expert friends worldwide on different topics. This week, we have the topic of the minimally invasive reconstructions, the minimally invasive rehabilitations in general, and we would like to know how do we achieve predictable aesthetics in minimally invasive rehabilitations. We've invited 3 great speakers for this topic. We've invited 3 great speakers for this topic, internationally, worldwide known lecturers. Christian has just presented them. Stefan Kubi from France, which is right next to me here in Geneva, then Marcello Calamita in Brazil, and then also Galip Gürel in Turkey. We would like to do this a little bit interdisciplinary. So all these 3 colleagues have a little bit a different area that they're covering within this topic. While Stefan will report on how he's implying the whole concept of minimally invasive dentistry in patients in worn dentitions. How do we approach these patients, communicate and pre-treat these patients in order to deliver predictable outcomes? What is the role of mock-ups? Marcello will tell us a little bit more of the vertical dimension of occlusion opening. Can we do this, or should we rather stick to more minimally invasive preparations in these restorations? While Galip will finalize this excellent series of lectures with a great topic, can we do the same thing on discolored teeth as well? Or how should we approach discolored teeth restoratively? Well, with this, I'd like to open up the session, and we will start with Stefan giving a little bit broad overview on the full mock-up concept. And before introducing his lecture and his topic, I'd like to introduce him, clearly enough. It's a colleague of ours from France. He comes from Marseille. He has studied at the University of Marseille. He's an associate professor there still since 2008. He obtained his PhD degree in 2011. So also academic career, but at the same time now also is running 2 private practices, one in Marseille and one in Paris. So I would say that's like the nicest locations that you can pick in France, probably. He is a great speaker. Undergraduate students as well as postgraduate dentists have delivered various awards to him as a speaker for his qualities. He's a member of Stile Italiano, and most importantly, he's the founder of a very, I would say, interesting institute since 2013 of the l'Institut de la Facette. So it's an institute, obviously, that's clinically and also training-wise focusing on minimally invasive restorations. And Stefan, before you start your lecture, I would like to do a poll with all our colleagues online here. And I would first like to see how much they know about the topic that you will address, how much they would do it this way or the other. So in order to launch the poll, I will give you now a question. In a patient case with pronounced tooth wear due to erosion or abrasion, which concept would you, as a private practitioner, as a clinician, maybe as an academician, expect to have the best long-term outcomes? Would it be conventional treatments with all ceramic full crowns, minimally invasive restorations with direct composites, Or would you go for indirect partial restorations, also minimally invasive, overlays, occlusive veneers, and overlay veneers? And I see the poll is already running. People are participating very actively, and it's a very competitive vote. So I cannot really share it with you yet because it's highly interesting. Also, Stefan, for you, it may completely change the concept of your lecture, probably. We will see. You don't know what they are telling me to do. Wait, it's still running, I see we have a very, very active participants group. Well, now it's slowing down and I think we can end the poll. I will end the poll not to take too much of your time, Stefan, and I'm sharing the results. Do you see them?
Yeah.
Are you surprised?
No, for me it's perfect.
Oh, that's boring. I think that you told them all to vote on.
I don't have to change my lecture, so it's okay. It's great. Okay, I'm happy.
Wonderful. Then I would like to pass the word on to you on the first lecture of this afternoon session, morning session, evening session, wherever you are at the world. We're very much looking forward to this.
Is it okay for the full screen for all of you? We can start?
Yes.
All of you?
We can start. It's perfect.
Okay, great. So, Irena, Christian, thank you very much for being with us. It's a great honor and also to be with Galip and with Marcello, because this is people that I deeply respect, like also Irena, since a long time. And it's a great honor, you know, just to share this 20-minute lecture with you on a topic which is, of course, very trendy and that we wanted just to, let's say, simplify a little bit, if simplify can be the good word. There is some important pillars in the contemporary dentistry, and we believe that everything has to be based on aesthetic. It has to follow some simple protocol, and it has to be guided in order to remove the importance of the skill. This is a way, I think, to get acceptance to the dental community to any kind of protocol that we are looking for. And also the discussion also, probably Marcello also will stress even more than me on this topic about digital. Is it also a good pathway to play with the topic of the word dentition? So of course, the main discussion today when you are a dentist is just to think about in which philosophy I want to be or I want to play with. Do I want to be a dentist of, let's say, yesterday with a kind of invasive approach with a prep concept? Do I want to be a very modern dentist with some prepless, which are for me, let's say, the main topic and the more secure in the lab and in the clinic? Or do I want to be very trendy and to go for the pure no prep, which is very, let's say, sexy on the podium, but which is not, let's say, my everyday bread? So I will stress on the topic of the prepless and just stressing on the function, especially treating the worn dentition and eroded dentition. So since more than 12 years or 15 years, let's say, we had a very nice article from Urs Belzer where he mentioned, you know, the paradigm shift, especially regarding the worn dentition. And let's say if we have to resume it, let's see that the biggest change, it is like the biology became the main pillar of the construction. And function and aesthetic, of course, are still very important, but first we want to produce material and to create material able to follow this minimally invasive, because we will use adhesive technology. And on this second part, regarding the treatment planning, everything will play and will be made according to the fact that we don't want to touch something which is already affected because of the wear process. So there is, let's say, a dentistry with enamel and without enamel. And this is why it's important to understand that if we can treat as early as possible and then to keep some enamel, the long-term behavior will be not at all the same, and we will be in the best scenario. If we don't have any more enamel, then of course the speed of the destruction will be 10 times higher. So this is some important, let's say, knowledge that we need to think about. The challenges for the dentist, let's say, is to understand how it's possible to go from A to Z. What is the pathway? What is the workflow? And for me, the key point is to understand how it's possible to move from the initial situation to the mock-up situation, because the mock-up is already the synthesis of already the final aesthetic outcome and the final functional outcome. All the change that let's say, we think about at the beginning as now completely materialized in the mouth of the patient. And after, to go between, let's say, the mock-up or the temporary and the final restoration, it is just what we can call everyday dentistry. So at the end of the day, we just want to stress on the three main keywords when we are speaking about everyday dentistry. It has to be feasible, it has to be teachable, and it has to be repeatable. And when we are out of this, I think it's difficult then to promote some technique which are not an easy access technique. So this is why we will just highlight the topic of the full mock-up through this clinical situation of this very nice and sympathetic lady who is living in Mexico, and she's coming from Thailand, but she's, let's say, married with a Marseillaise guy. So during summertime, she's back in Marseille. And as you can see here, you can see some, let's say, a lot of, let's say, erosion, where you see that we lost a lot of enamel. And when you lose enamel, unfortunately, you have to protect it or to recover a kind of artificial skin or artificial enamel. And this is what you have to explain to the patient. But let's say that the biggest issue is to recreate a skin, which is not that much complicated, but then the question is from where? And then we have, let's say, two main options, basically. Option one is not to touch the bite and the occlusion, and we just want, let's say, to focus about only the aesthetic, but then your restoration and the modification that you will provide won't be able to survive or to long last because of the fact that the new aesthetic won't be supported by a strong function behind. So this is why, let's say, basically, I would like any kind of dentist first to think as an architect when he's faced to that kind of severe, let's say, wear process. And thinking as an architect today means only to understand where would you like to create, let's say, the new white corridor. So I will just give you this example of a severe cases. And the main issue is not to find the good proportion or the new proportion. The biggest issue for me is just to know where do you want to place it in the mouth. Do you want to place it from the pink? Do you want to place it from the white? Or do you want maybe to place it from both sides and to make a compromise? Because as you know, in the one dentition, you have a huge aggression of the alveolar process, which is a kind of balance phenomena, just to fight against the wear process. So this means that the vertical dimension is not affected, but then you have still to play with, but for different reasons. So most part of the articles today agreed on the fact that if you want to get some space with a kind of free biological cost, you need to play with the bite by raising the vertical dimension, and not because we are looking for some aesthetic change. So the main reason is we don't want to touch some teeth which are already affected. So this is why to recreate the anatomy that we are looking for, we need space, and this space will come from the new bite. In terms of methodology, you have different tools as it was proposed, in the pool. One is, let's say, the minimally invasive, but in the pros way, as it was described by Mauro. Then you have the Geneva approach, which was for me really a huge plus, already 12 years ago from Francesca, where she proposed, that kind of sandwich technique. And in order to make a kind of synthesis and to continue a little bit what I learned from Francesca, we went for what we have called the full mock-up technique. And this full mock-up technique was directly linked, from what I learned from Galip 20 years ago in his book, where you have to place the future and cut from this future with exactly the required space that you are looking for. And I believe that that kind of way is a kind of a plug-and-play dentistry. And this is basically what we wanted to develop already almost 10 years ago, and was published, let's say, 2 years ago in the GPRD. So first, we place the future with a 3D printed template. We inject the bisacryl from the wax up. Then you have, to use this new mock-up in posterior area as a guide where you will cut through with a groove, with a special calibration, and then you will focus on, when you will remove this mock-up, you will have just to focus on the design with a very, very simple mark just to stabilize the restoration. But at that time, you won't be able, you won't like to already to continue to look for thickness because this issue will be already fixed. So we propose 4 main steps, which is supposed to resume 4 clinical appointments. So the first appointment is that we have to collect the data. And then after, let's say, the clinical picture, the model, it's very important, just to do by yourself the small freehand composite on the 2 incisional edge, just to place, already the horizontality in harmony with the interpupillary line. And same for the palatal area, in order, just to recreate the volume that we would like, to recreate just by freehand composite too. So once you have this, let's say, 2 rough composite, you have already a kind of references, and it will be exactly the same for the lower incisor that we would like also to improve. So you need, let's say, to materialize a little bit the final volume that you are looking for. And then you will have just to guide the patient in centriculation, and you will see what's going on in terms of posterior space available for the reconstruction that you are looking for. So if this space is already validated and you think that you have enough space according to your initial analysis, then you will know that you have, for example, for that case, to touch a little bit the upper part and a little bit the lower arch. Then you have just to see if the minimum thickness which is required for that kind of restoration will be available with the rise of vertical dimensions that you made with your small composite. If not, you have just to make some very slight adjustment. Playing with the vertical dimension is something very safe, but it will be even, I guess, much more developed by Marcello. And once you have recorded in an analogic way, this bite and this new space that you are looking for between the upper and lower, thanks to this jig, because at the end, this is a jig, then you have also today some new way, to record not only the new bite or the vertical dimension in static, but it can be also recorded in dynamic. And this is a French system from Maxime Gesson. And Mojo is something incredible because then you will get all the physiological envelope, even with your jig in the mouth, in order to place directly all the virtual anatomy and to reconstruct your full, let's say, wax up, but in a very fast way and with the perfect respect of the different movement and the envelope. So at the end, for a case like this, we will be in the option 3. So in the anterior area, the space that we would like to create will be split between my palatal veneers because I want to reconstruct the palatal anatomy and the lengthening of my lower incisor. So I will have to deal with both sides, but sometimes this is not the case. And in posterior, we will treat also upper and lower in order, just to recreate the anatomy that we have lost. So this means that when we will speak about number, we know that this number will have to be split. So from that, with all of this data, then our ceramist will be able, to produce a new anatomy that you will convert directly in the mouth, thanks to this technology, which is very accurate, which is coming from the 3D printing. And as you can see here, when you scan the wax up, then you have just to create an STL file and you will create a virtual template. And this virtual template, once it is done, you will be able to print it out. And after that, you will just reline the interior of this printed guide just with a light body silicone. All of this will be made, of course, from the lab. But on the, let's say, the outer will be very strong and the inner will be very flexible. And this flexibility will give the friction in order to avoid the pumping effect when you will place your full mock-up in the mouth with the silicone. Because with silicone, unfortunately, you can press too much or not enough, so it's not accurate. And the purpose of this is not to destroy the mock-up during half an hour. So once, let's say, you have that kind of very fast aesthetic and functional visualization, after that, it's time to play. So to play, what does it mean? It means treating first the upper arch, and you will have to stress and focus on two main points, which are the concern of the dentist. First, when you are faced to a mock-up, is the first concern is how deep has to be my cut. And to answer to this question, as you can see here, first you have the initial situation, then we have a work process. Thanks to the rise of the vertical dimension, we will create a new anatomy and we will cut 0.5 millimeter from this new anatomy. So this is why in most part of the time, we don't touch, let's say, the initial tooth structure. And I think that this is exactly the philosophy of the additive dentistry that is, I think, today mandatory. So just going back to what we are doing on the occlusal anatomy, we are making some groove of 0.5 through the mock-up with the round burr in order to use the shaft as a bite stop. So in the same appointment, we prepare the posterior first in order to keep the vertical dimension thanks to the anterior mock-up. And once we lock the posterior part with some bite registration or a record from a scan, then we can go for the anterior prep in order, to follow exactly, let's say, the basic workflow. So at that time, this is what we call really guided dentistry. And this is exactly what we are looking for. There is nothing which is related to artists or to art. This is not about the skill. This is just about protocol and repeatability. And this is why, let's say, even today, I wanted just to share, let's say, that kind of philosophy. When we speak about the design, it's always about going for this prepless approach where we prep like veneers prep for the buccal part and for a small round stop in the middle of the cingulum just for the stabilization of my palatal veneers. But the biggest change is in posterior because we went from the overlay to what we can call a Carpaccio design, where we will sit completely on the occlusal anatomy, keeping the marginal ridge. And of course, after you can have different type of design, which will be related to the severity of the case. So the more affected is the occlusal anatomy, the more important will be your restoration. So you can see for that cases, for example, we touch almost nothing. We needn't to make anesthesia for doing this. What we need is just to be sure that the patient, the ceramist will be able to visualize it. So then when you go to for the lab, the question is about the material himself. The material has to be monolithic in all of the case. It can be from analogic technology, from press, or it can be from digital. In the past, we were using to start, composite from the lab, which are working very well. The only issue is when you are dealing with that kind of acidic environment for bulimia and anorexia case, you can see that after years, it is suffering because of the resin matrix, and it is just a fact. Then when you go for hybrid block, you can get also some very interesting result with a better stability because, of course, of the property himself. But one also of the biggest advantages of that kind of material is the millability because you can go to 0.5. So, of course, it can be very thin, but as long as it is well bonded, then it's great. Same for the lithium disilicate, which is also one of our gold materials, especially in the analogic way because of the versatility of the press technique. When you go for the IMAX CAD, let's say the limitation is the thickness required because below 0.7, 0.8, sometimes it's difficult to be able to mill that kind of restoration. But if you have the space, we experience all the material for all this kind of full mouth rehabilitation the last 10 years. So, of course, we have a great experience and we are not, let's say, we were not disappointed by any kind of material of technology. After, it's a matter of equipment, collaboration with your technician. And when you receive all of this restoration, we believe in making an all-in-one bonding protocol from the palatal, and simultaneously it will be the palatal first and the buccal restoration in order to reconstruct the 360-degree of the tooth, but just with two partial bonded restoration, which will give us, this minimally invasive approach. And in the posterior area, it's, let's say, exactly the same because we like to bond one by one the restoration. So for the premolar, it's one pieces when it's possible. Sometimes it's also a sandwich. It depends on the severity of the case. And for the molar, it's just a simple tabletop occlusal veneer, which is just placed with a single individual dam because it takes between 7 minutes, 10 minutes just to make the bonding protocol. It's monolithic restoration and it's perfect. So then when the upper is finished, in the same appointment, you can just replace the mock-up, check some correction of the bite from your lower mock-up, and then you have to prep exactly following the same thing, but it takes honestly not a long time to make this guided concept. And after all of this simple design, except the fact that in the anterior, because we lost a lot of enamel in the lingual part for the incisor, and we had already a lot of dentin exposure, because of the mechanical, let's say, loading of the central incisor, we wanted, to have the seat belt and making just a peripheral approach just for the reason that we wanted to lengthen and we have a lot of dentin exposure. So we believed at that time that to have a huge flexibility during all the cycle of the protrusion was not the best way, to have a long lasting of our restoration. So for the bonding protocol of the lower arch, it's exactly the same. We follow the one by one. You will just have here a simple movie in order just to recap a little bit how it works. We sandblast, then we clean, we will etch, and you will have just to use some universal adhesive in order just to create a very good bonding, because this is the key of all of these restorations. That's why the bonding protocol has to be very strict and very repeatable. You need to spend times. It's not because you will lose 15 seconds more or less that it will change anything. But after making the bonding protocol, you have to sleep well, and it has to be the same for your patient. So we just inject, here it's just a light cure resin cement. It's a Variolink aesthetic light in that cases. So you can just see here the restoration with the very thin hole just in the middle. The excess, we apply the Optrasculpt because we want to have the perfect fit of the restoration. And after that, it's just time to light cure it. And we can get at the end, thanks to the beautiful work of my dear Gérald Dubassi, that kind of new complete full mouth rehabilitation, which is, I think, which fit perfectly with the requirement of the modern dentistry, which means making a lot, making something nice, and touching as less as possible. So at the end of the day, if we have just to make a simple conclusion to this, what we wanted through this lecture was just to be able to share with you, let's say, this protocol that we have developed. It took a lot of time, of course, and 10 years. Why? Because we believe that it's not because you make a case report that you just have to go to the community and to say, hey, I made it, and you can do it. Because when you propose a concept, it has already to face the clinical difficulty, because if something is complicated for you, there is a lot of chance that it could be complicated also for the other colleagues. So first you need to, let's say, to crack all the clinical issue. And when you have a very fluid and flow protocol, after that, you can go to the community and try to share it. So this is what we try to do. If you like this kind of topic, of course, you will be more than welcome in our training center. And if you like to read, as it was already very kindly explained by Christian and Irena, you will have this book that we wrote and was published just last year, and I will be happy if you find interest in all of that. So thank you again for all of you, and I'm looking forward to listen to my dear colleague Marcello. Thank you, Elena.
Thank you very much, Stefan. I think this was really like a great opening into this session. And you've shown your nice clinical outcomes and your nice clinical cases. I have a bunch of questions, but we will not discuss them right now. Do you see me? I see you, but I cannot hear you anymore. Anyways, dear colleagues, you have this chat function in your Zoom windows. So use the occasion to come up with your questions. You have 3 excellent speakers here, real experts in the field of minimally invasive dentistry. You can exchange your knowledge with them. You can ask them questions. So please ask your questions. We will have a discussion session afterwards. Well, after we've seen how to approach this type of rehabilitations, one of the main, I would say the main things that Stefan has mentioned is the opening of the vertical dimension. The question is now, can we open the vertical dimension without any problem? How much can we open the vertical dimension? And are we limited? And do we have to do preparations, or can we avoid preparations at all? For this, we've invited our next speaker, which is Marcelo Calamita from Brazil. He comes from Sao Paulo State. He studied at the University of Sao Paulo and is a specialist in prosthodontics. He has a master in sciences and also a PhD, so also academic background, and also works in a private practice. He is a clinical instructor at the university since many, many years. And I guess your postgraduate students are very blessed to have you there in the program, really to benefit from your clinical know-how. You're also associate professor, or you was associate professor at different other universities in the state of Sao Paulo in Brazil. I think most importantly, you're an aesthetic dentist, you're a minimally invasive dentist, you've been the president of the Brazilian Society of Aesthetic Dentistry. We're very happy that you will now share with us your know-how on this very specific questions. One of which is how much can we open the vertical dimension of occlusion. But Marcelo, before you start your lecture, I would again like to know from our audience, how much would they open the vertical dimension? Would they at all? Can we do this? And yes, how much? Up to 2 millimeters, up to 5, or even up to 1 centimeter? Are we limited or not? And let's see now what our, I would say, international audience says.
It depends, Irina. You have to mention that this is for dentates patients, right? Dentates and edentulous are different.
That's true, but minimally invasive rehabilitations normally are more for dentate patients. So I assume that our audience is sort of awake, either in the morning or in the evening or in the afternoon.
I'm making minimally invasive dentures as well.
Yeah, exactly. We have more than 1,000 participants in this webinar, and it's really great. I think they come from all over the world, and it's super to see what happens worldwide. Now I will come up with the results. Well, and you can see it's not an easy decision. It's somewhere between 2 and 5 millimeters. Nobody would dare to do more than 5 millimeters. So let's see what you say. So Marcelo, the stage is yours, the virtual stage.
Okay. Thank you very much. Thank you, Christian Hazi, for the invitation. Thank you, Irina, for the kind introduction. It's a pleasure to be here with Stefan Colby. Congratulations for your presentation, and also with my friend and mentor, Galip Gurel. So today in this 20 minutes, let me describe, let me say what I think it's important, because the bite leaf, when you talk about vertical dimension of occlusion, is a quite controversial topic. And this topic is loaded with myths, and you have to try to clarify, because it's so important. And nowadays, when you think about biologic restorations, biologic rehabilitations, I think the bite leaf, it's a good thing to consider when you are dealing with this kind of restorations. The problem is people usually think about the how, only about how to make it. And I think before doing that, the dentist should learn why you should make, why you should change, you should alter the vertical dimension. Is there are any kind of implications in terms of for the TMJ, for the muscles, for the phonetics? We have to discuss that. How much? You already mentioned that. How much? Of course, there are different scenarios, but for minimally invasive, as people already gave the answer, we should open the minimum as possible to restore all the teeth and to restore the occlusal.
Real quick, are you sharing a presentation?
No,
Yes, yes.
No, you're not. You
you
need to.
don't see it.
I'm sorry.
No, don't worry about it. I thought it was a monologue to chime in.
Okay.
There you go.
Okay. Now you can see.
Perfect.
I'm sorry. So just again to remember the topic, the bite leaf, and then we have to consider the different questions that are already mentioned to you. And the last one, is it safe? Stefan already mentioned one article by Jafar Abdul, and I'm going to explain a little bit. I'm going to go a little bit farther. So how we have different point of views, but if you go to the literature, many this answer is, you have a lot of answers, but most of them are related to dangers. When you see it, facial proportions, freeway space, deglutition, phonetics, most of them are related to dangers, which is quite difficult to do, not only because of the vertical, because you are repositioning all the teeth in the space. So it's quite more difficult, and it's another topic. When you deal with minimally invasive restorations, we already have the references there. The references are still there. You have to change as minimal as possible. Of course, you can use ortho, as Galip is going to mention. You can use, you can indicate orthognathic surgery, but most of the time, we're just going to add tooth structure in the places that the tooth structure was already worn. So thinking about the treatment planning, we have the different phases for the treatment planning. We have the incisal edge position that is going to define everything. And from this point on, you have to discuss two things at almost the same time: maxillomandibular relationship and vertical dimension, because they are quite related. We cannot discuss vertical dimension without talking a little bit about in which position you're going to open the vertical, in MIP or in CR. And then after that, we can discuss, but not today, we can discuss how we're going to define our functional pathways and how we're going to provide the posterior support. But today, let's talk a little bit about the vertical dimension. We have to think about, when you are planning, the static is going to define, it's the most important thing, not because we don't pay attention to the function. No, it's because the static is going to define the phonetic. In this very first moment, the phonetic is the dental-labial sounds, and also it is going to establish the anterior limit of the protrusive trajectory. So this is important. When you think about statics, you are not only thinking about static, you are thinking about the interrelationship from the statics and phonetics, and also the mandibular plane and function. When you think about the lowers, it's the same thing, statics, phonetics, now related with the S sound. The S sound are quite tricky because you don't have too much room to play with it. The S sound requires about 1 millimeter for you to pronounce sharp sounds, sharp S sounds, so we have to take care with that. So it's not only, please, this is important, not only about the vertical. In this very moment, you have to pay attention to the interrelationship between the upper teeth and the lower teeth, and not only the vertical, but also the horizontal relationship. If you don't position the upper edge, for example, you don't have a crispy S sound, not because of the vertical, but because of the position of the edge is not correct. And everything occurs at the same time. You have to pay attention to that. So remember, please, that the statics will determine the anterior functional borders. So when you think about statics, we start to think about function at the same time, because the statics you can have some conflicts when you define the aesthetics, and this conflict should be negotiated. Sometimes you have to change a little bit the overbite, in order to consider all the anterior determinants of occlusion, because these patients, the one, for example, that Stefan showed, They come to your office with a worn dentition, so you don't have any kind of guidance, any kind of anterior pathways. And it doesn't mean that just have to put like an obstacle in front of the mouth and you're going to think that it's going to work. No, you have to provide an anterior disclusion, of course, but as shallow as possible, because if you put a shallow guidance, enough to disclude the posteriors, is going to increase, you're going to have less forces, tension forces and shear forces in the anterior teeth and in the anterior restoration. This is a very important thing. So please, when you think about to open the vertical, first of all, you have to make a proper examination, anamnesis examination. This is called functional examination. And you have to be sure that your TMJ is healthy, that the muscles are healthy in order to open the vertical. If you don't want patient to that, sometimes you can have issues with that, because when I talk to the students, when I talk to my colleagues, I think we have to mention that the most important thing is what are the implications from the examinations and the exam findings. They are the most important implications are about the predictability. Is it predictable for me to treat this patient? And also, what are the risks? You have to ponder. You have to ponder the risk versus benefits for the patient. This is quite important. So let's go straight to the point, talk now a little bit about the maxillomandibular relationship and the vertical dimension. When you open the vertical, this is very important. When you open the vertical, you don't have the inclines from the teeth to define the position of the mandible. So you cannot trust in the teeth position. You have to trust in another reference. And the reference, the most stable, the most reproducible, and also the verifiable position is CR. Please don't mystify the position. This is a position of prosthetic convenience, and it is reproducible over time, the most reproducible position over time. And it's very convenient for us to work with that as prosthodontists. Just that, as independent of tooth contact, as we are changing the tooth contacts, it's very important for us to understand that. So we have to know how to use that. We have to put this mandible ECR with different techniques. The one that you master, manipulation, lucha jig, lift gauge, it doesn't matter. You have just to put the mandible. This is very, very important. I think this is key. The key is the position of the mandible. It's not actually the vertical. This is very important for you to remember. And then we have our paper. We published this paper. Christian Coachman, Newton Sesma, John Coys, and myself last year in International Journal of Aesthetic Dentistry. This paper was already translated to German, to Italian, and Spanish, and also Portuguese. You can find the International Journal from Quintessence. And there we summarize the important thing that the dentist should know, the must-knows of vertical dimension in this review. First of all, the vertical dimension promotes dental-facial aesthetic harmony. It's true when you are dealing with dentures, when you are dealing with implant reconstructions, because you have to open a lot. You have to open open at least 5 to 6 millimeters in order for the observers to notice that. That is important for you to know. If you open just 1 millimeter, 2 millimeter, 3 millimeter, the observer cannot notice that. So you cannot promise to the patient that you're going to make him or her younger after the treatment. This is important. Not only that paper by Martin Gross, but this one by Orenstein this is more recent, that you have to make increases of more than 5 millimeters in order to get noticed. This one is the topic. We get space for restorative material. It is a biological approach. Why? Because you just open the vertical to add tooth structure, to add material in the tooth structure that was already worn down. That's why I think the vertical dimension is changing the vertical dimension is a biological approach. And also, when you are opening the vertical, you can improve the maxillomandibular relationships. You can provide axial loads. You can work with the overjet. I mean, diminish the increase the overjet, diminish the overbite, and also flatten the angle of disclusion. These are occlusal requirements. I think good occlusal requirement. Is it safe? As Stefan already mentioned, it is safe. He quoted the article by Jafar Abdul, but also Charles McNeil, and you can see here Moreno Hay and Jeffrey Okerson. If you don't open too much, because when you open too much, it requires, you're going to force the adaptive capacity from the patient. And some patients, most of the patients will respond well, but some patients maybe not. From my clinical experience, I can tell you more than 90% will respond well. But please, when you open the vertical, if you are not sure, actually, I recommend that you have always to open in a reversible way, using provisionals. You have always to first using provisionals to check if everything is okay. Not only the vertical, but if the bite is adjusted in the new vertical. So the implications, as already mentioned, on teeth, on TMJs, and muscles, and phonetics, depends. It depends because you can have some discomfort, transient discomfort, but usually it's related about how well is adjusted the new occlusion. Because when you open the vertical, you are reconstructing the bite in a new three-dimensional in the space. So you have to adjust that. You have to adjust the posteriors and you have to adjust also the anteriors. When you adjust that properly, the patient will respond well. The neuromuscular system from the patient will respond well. So depending on the case, as you can see here, I'm sorry, if you remember the graphic from Posselt, and now you can use the Mojaw, as Stefan also showed, this is a nice analysis and also design tool when you are dealing with the digital manufacturing. When the patient open the bite, the mandible goes down and back. So there is a relationship. It's called 1, 2, 3. If you read this paper by Rebibo and Professor Ortelieb from the University of Marseille, this just for you to have a reference. So depending on the case, if you have a class 1 patient, class 2 patient, class 3 patient, angle classification, you can play with that. From usually class 1 patient, you can play safely, you can open the bite and still have an anterior stabilizing contact. For class 2 patients, when you open too much, you miss the anterior point of stabilization. So you cannot open, unfortunately, too much for class 2 patients. And for class 3 patients, you can compensate. I'm not saying that compensation is a good thing. It's my choice, as my first option. But I can tell you that many class 3 patients or pseudo class 3 patients, you can compensate and you can provide a nice occlusion for them, and it's going to work properly. And once you provide shallow anterior relationships. So you cannot open too much, because sometimes if you open too much, that's why Irina asked you, if you open too much, we start losing the anterior natural anatomy. So sometimes the patient cannot pronounce properly the S sounds, not because of the vertical, it's because the tooth, the anterior teeth is not natural. So the patient cannot pronounce certain sounds. So that's so important. If you have to open too much, maybe you have to introduce orthodontic and orthognathic in your treatment planning. So these are the case. We have different scenarios. Just to give an example, we always have to do, this is a mock-up. This is not only a static mock-up, but exactly as Stefan showed, a static and functional mock-up. So the patient first should try it, and then we did this kind of digital planning. We cemented everything in the mouth. This is, you can see the anterior are 6-unit anteriors because it's easy for the patient to clean, and all the posteriors PMMA provisional cemented individually, single units, and then you adjust. And once the patient is feeling comfortable, the occlusion is stable, you can go to the final. So it takes like very quickly. And exactly the same protocol as Stefan showed. This one, the difference is everything is milled, everything is monolithic material. This is the Empress crowns milled. Oh, actually, I'm sorry, Empress crowns, Empress inlays, onlays, and veneers, not only crowns. You have a mix of that. And the same thing here, just for you to know, depending on the situation, you can play with the lift gauge, for example. You can play with the lift gauge, for example, how much you should open. 1 millimeter is not that much. 2.5 millimeter, just an example for this patient. And then you think that you're going to recover 1 millimeter for the lower anteriors, 1.5 millimeters for the upper anteriors and the lingual, something like this. And then you take the registration already almost in the final, in the restorative OVD, which is quite nice because you remove the axis of rotation from the articulation, that you know that the axis of the articulator is not the same as in the mouth. If you remove that from the equation, you have more precision. So it's the same thing, you plan, and always you have to do that. Cement all the provisional and test. Once it's tested, you can go to the finals. This is very important. So the conclusions from these presentations are, the therapeutically designed OVD should not be considered an immutable reference point, but rather a dynamic dimension within a zone of physiological tolerance. Second, the alteration of the OVD should be the minimum necessary to harmonize dental-facial aesthetics, provide space for the planned restorations, and improve the occlusal relationship. And third, vertical dimension alteration should not provide long-term deleterious aesthetic, functional, biomechanical, or biological implications, as long as an equilibrated and stable maxillomandibular and anterior tooth relationships are respected. So I would like to thank you. Irina, you know me, always speaking fast, a lot of things happening at the same time. I'm sorry for that, but I cannot do differently.
No, I think it was just perfect, Marcelo, I have to say, because these questions that you have just now addressed and I would say very nicely elaborated, also very nicely. You see, I'm an academic person, so we always look for evidence, and you really looked into the literature and you have really shown what the range is. And still, besides all this range published in the literature, there are a lot of aesthetic factors, functional factors that play a significant role, which then bring me back to Stefan's initial lecture. You know, this mock-up situation is obviously a very crucial one, because this is the one where you test everything. And we have a number of questions coming up from our audience worldwide. We have audience from South America, which is not only Brazil, but also Mexico, up to Saudi Arabia. So we're really all around the globe connected at the moment, and that's really great. We're collecting the questions for the discussion in the end. Thank you very much for your contribution.
Thank you.
Such as also Stefan's was excellent. I would like to introduce the third speaker, who is addressing a topic which is at least as critically looked at as the opening of the vertical dimension. It's discolored teeth. So we would like to stay least invasive. Now we know that we can open up the vertical dimension to save tooth substance in the posterior region, but what if the patient has discolorations? And for this, we have invited the Galip Gürel to lecture for us. Galip Gürel, who is very also well known for his concept in veneers, and I don't need to introduce you like the other speakers as well too much. People know you, you're from Istanbul, you've studied at the University of Istanbul, you've then done a specialization program in the US, like many people do in prosthodontics, you've done it in Kentucky. You're I would say, for me, one of the role models as a past president of the European Academy of Aesthetic Dentistry, that's clear. Also as a founder of the Turkish Academy of Aesthetic Dentistry. And you have published a lot of literature, books, and also articles. I think your concepts are worldwide known and applied. And you've seen in the first videos that also Stefan has shown that, you know, prepping through the mock-up and so on. You know, we know where this comes from. And I think there is a lot of clinical experience and also scientific thinking besides all the clinical expertise in your concepts. And you're teaching them also in your Institute for Aesthetic Dentistry. Still, you know, after we've learned a lot about opening vertical dimension and staying least invasive, we have the problem of patients with non-vital discolored teeth that we have to address. And Galip, before I give you the word to address this, I would again like to launch the poll to see what our viewers think about the fact that in patient situation with severely discolored teeth, what can we do? Can we still stay minimally invasive? Do we have to do more invasive treatments? And do we have to even do a post and core buildup, like a white post, a zirconia, or a glass fiber post, and a white buildup in order to be able to stay aesthetic, as we would always like to stay aesthetic? And the poll is running now. We will see. I'm very much looking forward to your lecture, because I also would like to know how invasive do we have to get when the teeth are discolored? And if we want to stay least invasive, what can we do in order to stay least invasive? We will still, the poll is still running. We will end it in a second. It's I would say also more clear result than I thought. Let me share it with you. You see that our participants think, yeah, we can stay less invasive. Well, I'm not so sure about that. So let's see what you recommend us to do. So Galip, thank you very much for accepting this invitation. And I pass the word on to you. Please share your screen. Exactly. Thank you very much.
Okay, Irene, for the great intro. And thanks to Steph and Marcelo for an amazing lecture just before I started. So you've given me the topic of pathways to being minimally invasive on discolored tooth. But before getting into this topic, I would like to mention about the basics of the aesthetic steps we take in any case, whether they are like this complicated, whether they are going to be held in an interdisciplinary fashion. Well, I don't care, veneer case, crown bridge case, implant case. I think we have 3 must follow main steps to be on the safe side. And even today, in every single case in our office, we apply these 3 steps. So very, very simple, basic. The patient presenting short teeth, negative smile design, partially discolored dentition. So I have to go through these 3 basic steps, and towards the end of my lecture, I will try to relate those steps on how we take some precautions, which steps we have to take while dealing with discolored dentition. So the first step I would always prefer will be a direct mock-up. So once we have this, we will start getting in a visual communication with the patient. And this can be your first appointment as a direct mock-up in the patient's mouth. It can be a digital design, which you may introduce to the patient in your second appointment, or it can even be an analog wax-up, preferably done through this direct mock-up. So once we have this converted into a 3D wax up, then comes my second thought, which made my life so easier going all the way back 25 years, deciding to use this wax up, applying this into the patient's mouth prior to we start working out in any case, because here the patient is still fresh, the lips are not numb, and as both speakers mentioned, it's a great time not only to analyze the aesthetic outcome, which is crucial, but also function and phonetics throughout this APT, aesthetic pre-evaluative temporary. So with that, I mean, it will ease our comfort, and whether we will decide on whether the treatment plan is realistic or unrealistic. If we need to go into interdisciplinary work, well, that will be a guide for the orthodontist or the periodontist, either to change the setup of the teeth or soft tissue levels. So with this APT being in mind, that refers mostly, besides of course function and phonetics, the design of the case. And no matter what the conditions are, we should get that into a level that should accept the treatment. Because of some functional reasons or so, if we cannot deliver such a smile, doesn't matter how hard we work, the patients will not like the final result. So this is a must to start a case. We should finalize most of the details at that stage. Then it comes to the third stage, as you mentioned, keeping this final design as a reference, the solid reference on the facial portion of our wax up, prepping through the APT. And that will give us the ideal minimally invasive approach in your case, or in any case, restoratively, you'll be working depending on the differences of the depth cut. So we will prep these teeth through and simply get to see that many of the time, I can say 100%, we'll get the exact depth that we needed to work with that case. So this refers, prepping through the APT is now referring to being minimally invasive. So with that, we'll go prepless, we'll preserve the enamel, and we will be able to manage the color better. And I'll go into details soon what these mean. So in this case, we were using pressable Emax LTB1, a little bit incisal layering, and I think the outcome is quite acceptable. A case done with Christian. This is a case probably 15 years old, but overall, we got a great design result just because we set the tone in the beginning, communicated that with the patient and the lab. Accordingly, the design of the ceramic and the thickness of the ceramic, which I will address in a second. So all these basic rules are still the heart of my book that I published in 2003 from Quintessence. And honestly, even today, if you go analog, digital, if you don't take care of these steps, I mean, the chances of being successful will be minimized. Now, a very quick tour of terminology of being minimally invasive. We can have no prep designs, like you see, without touching the tooth preparation. Without touching the tooth, with no prep, we do the veneers. Realistically, in my office, this is less than 1%. Prepless cases, which are great, just addressing the margins and presenting a very thin veneer. Minimal prep cases, which the thickness of the veneer will be around 0.3 millimeters. Normal prep cases, the prep design will be 0.5 to 0.67. And on top of that, depending situation, after preps, 360 degrees veneers, glow crowns or veneers, and all the way down to a jacket crown. So this being said, for being minimally invasive, I think we have 3 parameters that we really have to focus on. And with those variables, we can control most of the things in our minimally invasive approaches. So the first step or parameter is the design. The second one is the materials and the technique. And the third one is the position of the tooth. Okay, let me briefly explain this. When it comes to design, it starts with a direct mock-up. It can be a wax-up, preferably a continuation of the direct mock-up, or a 3D digital wax-up. So that will set the tone of our treatment and final result. Having said that, when we are doing this mock-up, wax-up, this is regardless of the tooth position. Of course, I'm not talking about extremely protruded, but in general, that will set the tone. And it doesn't matter, as you will see here, as opposed to the final aesthetic contour of the design, if the tooth is like slightly protruded, like you see on the right side of the screen, or slightly retroclined. It will only affect the thickness of the material I use for the mock-up, but my final contour remains the same just because it represents the final aesthetic outcome. So with that, keep contour as a starting point together with the incisors, which I'm not mentioning this in this lecture, but as the facial contour of this design. That brings us to the second step, which is the thickness of the veneer. And it's all dependent on materials and technique. So we can have an average thickness of a veneer, 0.3, 0.5. We can have a thin veneer, 0.1, 0.2, or we can have a thick veneer, grade 0.6, let's say. But how we determine thickness is mainly based on the color changes. So it's about what shade we are now and what shade we want to be at the end of our treatment. And this is mostly color-based. I know that we have different type of ingots. So it is a combination of what ingot you want to use, how natural the end result you want to end up with, and how thick or thin you would want to your veneer. And this was another article we published with dearest Marcelo and of course Christian at the GPRD regarding the math we use, which I will address in a few seconds, on the thickness of the veneers. So in general, we can have thin veneers down to 0.2, 0.1. These are valid for maybe a single shade change, or we can have thick veneers, like here you can see converting an A4 to B1. And in average, this is like 0.1, 0.5, 0.15 or 0.20, depending on the technician, the materials, as I mentioned previously. But in every color change, we will need to increase the thickness. And the third thing that is important is the position of the tooth. Watching this blue line as a final destination, the tooth preparation will change in a different way if the tooth is being outside of the aesthetic zone or more palatally positioned. So with all these things in our mind, how does it affect the tooth preparation? Let's do a math. Well, the first thing, as I mentioned to you, is the mock-up. This mock-up defines the outer layer of our design. The second part is the thickness of the veneer that we decided upon the material of choice, color, and the color change we will try to end up during this treatment. And when I will extract that thickness from the mock-up, I will gently see, as you see on the right side of the screen, the overlapping part that is on the tooth will define the preparation amount we will be going forward. So assuming that the red line is on dentin, I think it makes sense that it's better remaining on enamel when we make our preps. So we will have the mock-up design, we will have the thickness of the veneer, and the tooth position, positive or negative, will affect the thickness of the tooth we will be preparing. So like as you see here, within the same setup, if tooth was more protrusively, like you see here, with the same prep, we will be going into the dentine. Or if it's palatally positioned, maybe I will easily go prepless. So if the thickness of my mock-up is equal to the thickness of my veneer thickness, let's say, then I will either go no prep or prepless. So this is the simple equation. Now, why am I stressing too much on being prepless? Because this enamel is invaluable. The way it connects to dentin with the dento-enamel junction, the way it bonds it physically, and the way it scatters the light, giving all this natural effect to the look of the tooth. So we made a retrospective study that refers to the strength and when you look at the past studies, retrospective studies done by Mark Friedman, who was one of the leaders in veneers going all the way 30 years back, Bayer, Funemans, and including ourselves, we see that the success rates are around 93%. And I know these guys are amazing clinicians. It's not just because they made a step wrong during bonding and the problems occur. No, this is like everything being done correctly. The success rates are at this level. Now, what made our research different is that besides the overall success rates, which is around 93%, we divided the way the teeth are prepped. We divided the research into two. One, preps limited to enamel versus the preps limited more than 50% dentin exposure. And when we look at the results, when we are limited to the enamel, we go all the way up almost to 90. And see down below, if we are exposing too much dentin, the success rate comes down way below the average. So keeping this in mind, which was published at the GPRD, again with dearest Marcelo, two different articles based on this concept, we also have to realize the optical effects on what is going on in a natural tooth. So I would like to thank dearest Hilal, who also works with Steph all the time, to his slides that he provided me. So what was done on those is that we will be seeing the tooth with normal daylight. We see that the enamel has a high value. Now we're looking at it not from a bonding strength point, but we're looking at it from an aesthetic point. So we have high value on the enamel. And when we strip half of the tooth down to dentin, as you see on the right side of the tooth, then we will see the low value dentin. So with all these things, if we want to pick up pieces over that tooth, we will be seeing that there are numerous differences between value and chroma from the same tooth itself. Now, what gathers and wraps it around is the enamel. So it's the best sealant of the color because of its optical effects. It's a perfect envelope to keep everything aesthetically intact as well. So the moral of the story, the more you prep into the dentin, or the deeper you prep, the more trouble you will be in. So our aim as the topic of this whole prosthetic session of Quintessence is that trying to be as minimally as invasive and try to keep that very precious enamel over the tooth surface. So we also tried a few other things in the lab using the Emax MT ingots. Hilal prepared 3 different ingots, 3 different veneers. And when you look at these, and when you want to see the value difference, in my opinion, with my first look, and we surveyed it through many of the course participants, that they valued the middle one as the highest value, the one on the right with okay value, the one on the left is with the lowest value. But in reality, when we look at the ingots we used, actually the one on the right should have the highest value. It's bleach free, it's the lightest color. But the difference here was actually the thickness of the veneer Hilal produced. So to trick them, we used a 0.3 millimeter thick veneer on the tooth, which we have given bleach free, and the others were 0.5. And that thickness, getting thickness less and less, lowered our value. So you're working with the pressable ingots, let's say, anything less than 0.3, we will be losing the property of the material, hence the value. So if we use ingots for microlayering, for staining, then both Hilal and I would propose that keeping the thickness not less than 0.5 will reflect the real value of the ingot itself, thus the enamel and the overall value of the case. So how do we relate this into, let's say, a tetracycline case? Now, when we're talking about tetracycline cases, the teeth that are exposed to tetracycline, whether in or out of utero, at the time of tooth mineralization or calcification, tetracycline will bind to calcium ions in the teeth, and upon eruption of the teeth and exposure to light, the calcium bound to tetracycline oxidize, causing the discoloration to change from fluorescent yellow to a non-fluorescent brown over a time of months to years. So you see that the core color of the tooth changed deeply in a very darker fashion. So what is the solution? When a patient comes with such a problem, how do we continue? Well, the first thing that comes to everyone's ideas is that using a thicker veneer, and nothing wrong with that. So if we choose the thickest layer, let's say, the patient is happy with the position of the tooth. So we will, prepare the tooth, even if it's through the APT, but we will simply see that we will definitely end up in deep dentin. And especially in tetracycline cases, the deeper the dentin, the darker the substrate gets. So doesn't matter how thick the veneer will be, you will definitely be seeing the absorption of darkness through the inside of the tooth reflecting to the outside of the veneer. So what is our other alternative? Other alternative is trying to work additive, which is great, and it's even better work more additive. So this is great because we will be creating a space between the tooth and the outer layer of our ceramic, which will give us the chance to use a thicker veneer. Okay, so now if we talk about the math again, if the thickness of our veneer will be equal to the thickness of our final ceramic, well, then we can be talking about prepless veneers, which is like the ideal solution. I'm not saying no prep, but prepless. Okay, so let's go back to the case and see how we proceeded. Well, here's the case with the tetracycline discoloration, and regardless of the case, extremely crowded, spaced color changes. When I see a first page, first thing, aesthetic perspective, I do a mock-up. So this is what I'm doing to this patient right away. And I'm trying to be as additive as possible because I know that if I gain that space with my mock-up, I'll be well off. So the thickness he accepts maximum was 0.3. It was a little bit disappointing because I know that I can't solve this problem with a veneer that will be 0.3 thickness. So how am I going to continue? Well, that brings us to the second part, the thickness of the veneer. So what should be that thickness? So for that, we found a different way. That was very original for us because this case is done probably 15 years back. So what we tried to do is we prepared a set of veneers that we will place on the same tooth. That was tooth number 22. The left upper lateral, both 0.6 millimeters and 0.3 millimeters with different ingots. So what we did was we start placing this over the tooth. This was experimental. You can downsize the number of these veneers into maybe 1 or 2 or 3, but it may save your life. So what we did was, without taking the arch position, mock-up position, without taking account, we started placing these veneers one by one over the same tooth. And you see here, the first one is from Express LTB1. The other one is from the same family, MO0, Opile 1. And you see different colors coming out from the tooth. Value 3, which refers to MT as of today's numeration. So these are the 0.6 millimeters veneers, draft veneers, we tried over the teeth. And then we did the same with 0.3 millimeter thickness, hoping that the patient may like the outcome of that, so I would be well off just almost prepping the teeth for nothing and finalizing my case. So these were the 0.3 thicknesses and 0.6. So we all evaluated these different options with our team, with the patient, with the lab, and like the poll you're making, the one was the value 0.6 thickness veneer. So from here on, we will take this to continue with our treatment. Now we have a problem. What is the problem? With my mock-up, with my best efforts to pump it out, the maximum aesthetic contour was 0.3 millimeters away from the tooth. And on the other side, the veneer we have chosen was 0.6. So if we put this into the do the math equation, we have the mock-up 0.3, we had the thickness of the veneer 0.6. So if I subtract it from the first one, we are 0.3 in negative. That means we had to prep the teeth 0.3. And we know that the thickness of this enamel at that age is almost like 0.3. And if I continue with that, I would be ending up again dentin, even if I'd use my APT, prep through the APT, whatever you name it. And then that will be a problem. So now I got a bit trapped on whether to add more to the design or use a thinner veneer. But at the same time, we also remember the third option, which is the tooth position. What does this mean? Well, this means if we can move things orthodontically, maybe we'll be better off. So the aesthetic contour of the APT is fixed. We cannot change it. The thickness of the veneer is fixed. We cannot change it. But one thing we can do here is maybe to move the tooth more palatally, as you see here. The contours remaining same. Now I'm getting the tooth out of my way. And when I will prep the tooth through here, I will end up with a very nice prep, limited on enamel, limited on the enamel substrate. So immediately we go treating the case with the aligners. This is coming to the end. And then dilemma here, which goes in almost all my interdisciplinary cases. What is this? Besides the color. For some reason, if I'm changing the position of the teeth, the biggest question remains between myself and the orthodontist, because he says, I think I'm done, and I don't know if we are done or not. So the communication here with the orthodontist will be through my second mock-up based on the new positions of the teeth. So in my second mock-up, as you see, I start with my centrals. I'm adding this 0.6 meters so, and then continuing with the laterals and then the canines. So with that, if the patient is okay with this, we're done. If not, we will continue further bringing the teeth in. So how do I decide on that? I'll make a silicone index from my last mock-up, place it over the teeth, and like you see on the left, if I see the enough space for my veneers, even without prepping the teeth, I'm done with ortho. So this is where we are in 7 months. Nice arch position. We moved the 0.3, we moved the lower teeth 0.6, so it had to be double the space also for the lower veneers by stripping the teeth, and then creating that space not only for the maxillary teeth but also for the mandibular teeth, and applying our provisional on top of that. So this provisional is not only to check the aesthetic outcome, but like as Marcelo and Steph beautifully managed, trying to see the relationship, the new relationship between the two, the upper and lower incisors. Because as Marcelo beautifully showed in his lecture, depending on the combination of the angle of disclusion, overbite, overjet, I have to see which 5 R's I need from his classification. So in this case, I had to use the 3 as a case like this. The first R, ortho. We have already been through that. The second is reshaping the opposing teeth. In that case, the opposing teeth is the lower mock-up, so I can easily adjust it. And the third one, reducing the restoration teeth side. I already brought it to a level that I won't be able to, I don't need to bring it even more further inside. In the condition that if I could have ended up with a very tight relationship in the anterior, well, then we might consider opening the video as beautifully lectured previously. So this is the final wax up, copying my second mock-up. This is the trial of this in the patient's mouth. Again, all the same workflow, prep the APT. And in the lower, as you can see, it came to a level that it's going to be almost no prep. So what I do here is just go through the margin slightly with a round burr, and then I define the incisor interproximal line angles, polish the surface, and as you see here, I'm all on enamel except for a tiny bit of surface on the margins. In tetracycline case, have to be about this interproximal elbow that we need to hide it so that the new color will cover up the color of the original tooth. The same goes on for the upper teeth. See, almost prepless, minimally invasive, marginal preps, that's it. And the final result that we get through this case. So it was a great work of Adriano, our ceramist from Brazil. And even if it looked like a very tough case, both upper and lower, using some tools of aesthetic design elements, we managed to bring the teeth, the thickness of the ceramic and the position of the tooth in an equilibration that we not only have been minimally invasive, but we reached our goal in terms of the outcome and occlusion. So this patient, like after 13 years, still everything is intact, beautifully positioned in his mouth. He is extremely happy with the color. And so as me, I'm sure our team, Elif and Adriano, who were involved in this case, were extremely happy. So with that, I really would like to thank you for inviting me to this amazing, amazing webinar. And you're more than welcome to forward any questions you want to me at any time. Thank you.
Thank you very much, Galip. Thank you, the three of you, Marcelo, Stefan, and Galip. Congratulations. I have to say I've been receiving lots of messages here and also lots of questions. And compliments to the three of you, also to Christian as an organizer, and everybody's happy. We've also received some warm regards from Jordan. So there is really a very international population here around us. We have, I would say, a few minutes for the discussion still. And it's great maybe to have all of you together in this discussion. I'd like to start with you, Galip, first, because this is really a specific question for the discolored teeth. It's a question that came up to my mind when I was listening to you. You were talking about orthodontics, about the different thicknesses of the ceramics and so on, but you never mentioned bleaching or microabrasion as a, I would say, interdisciplinary means to improve the abutment tooth before the veneer.
It's a great question, Irena. I mean, I can only reflect my clinical experience on that. Microabrasion works better than bleaching because bleaching, okay, I mean, you know, in some cases it works better, in some cases it doesn't. But one thing for sure, even if you bleached it to an extreme level or less, over time it will bounce back. So, I mean,
would you say it's the same for external and internal bleaching? So if you have a non-vital tooth and you would do an...
No. Internal bleaching is completely different. Definitely, I will go for an internal bleaching, try to equalize the color. That happens in like a single root canal treated tooth. Yeah. I'm talking in general discolorations. Yeah. So in those, I would rather kill myself to get the final result through what is existing, instead of bleaching the teeth, placing my veneers, getting a fake brighter color, and in a year's or 2 years' time, patients coming back to me saying these teeth are getting darker. Yeah. So in those situations, personally, I wouldn't prefer bleaching. I would just go with whatever I have in my hands.
Yes. And if you have in your hands to do orthodontic pre-treatment to gain the space, because you want to be additive and you want to be as least invasive as possible. Sometimes it's not possible, so you need the orthodontist. How much time does it take you in collaboration with the orthodontist to pre-treat the case so it's ready for your veneers?
It all depends. Like in this case, this was, I think, 7 months. I mean, I have thousands of cases I can share. Sometimes we go 2 years. But one thing we do in our office is that our orthodontist is only taking care of adult orthodontics. Thanks to Nuno, we do tons of ortho cases. I would say 50% of our aesthetic cases as a pre-alignment for the final aesthetic job.
Yeah. Thank you very much, Galip. And then I have questions that concern you all because they're really related to minimally invasive dentistry. You know, we're building up on the fact that we have enamel because we're so much dependent on enamel. And what do we do specifically anterior and also posterior regions if we have loss of enamel or just little islands of enamel, like all these erosion, abrasion cases? So how do you decide in this case? And maybe we can make a round. Start with Stefan, you first, and go through Marcelo back to Galip, so Galip can rest a little more.
Yeah, it's yes, I like this question because I think it's highly related also to the function of the tooth. Because, for example, in most part of the case in posterior, in eroded dentition, we have dentine exposure, sometimes with some enamel island in the middle. But many cases we have just, let's say, a belt of enamel, but the occlusal anatomy is already with only dentine. But the question is about the biomechanics. So if we bond on top of that, there is different references where they show that according to the substrate, you have to go more for composite if you have a lot of dentine exposure than to go for enamel, and if you for ceramic, and opposite if you have some ceramic, it could be better to get some enamel to bond. Honestly, from my point of view, I don't see a very big differences in the practice, if I have to be honest. Why? Because for the posterior, let's say the main loading effort is about axial forces. So which means compression of the material. So let's say my interface is not, let's say, a lot solicited. If I go for the lower incisors, this is what I said very fast at the end of my presentation, we preferred not to go for veneers because first we had some loss of enamel in the lingual part and we have so to protect it. And second, we have a lot of dentine exposure in the facial part. So if you apply veneers and you just bond like this, what happened during all the dynamic of the patient? You will have a tension on the interface. And if you have a tension with a lot of dentine exposure, I think that what Galip already mentioned during in his own literature and also through the different one, you can see that the survival rate are not at all the same. So my patients are not, let's say, cobayes. So if you want to sleep well, there is a huge potential for adhesive dentistry as long as you respect, let's say, the gold standard. And if you want to be a little bit to go off-road, then after it's, let's say, more difficult.
Maybe we're more conservative here in Europe. I don't know. Let's see what Brazil says to this. How do you approach in South America the cases where you have you would like to stay least invasive? It's a young patient. It's a, I would say, healthy patient, but maybe out of health reasons or out of nutritional reasons comes with a lot of loss of tooth substance and dentin exposed. Would you be as conservative as we are here?
Which is a quite common situation nowadays, and it's becoming more and more common especially because of the diet, because of the problems, gastrointestinal problems, everything. So I think that the enamel is the most precious structure that we have in the body. So we have to make everything in order to save it. So I just try to level. For example, usually we take advantage of open the vertical, as we already mentioned, for these cases. I try to open the necessary, what I consider is necessary for giving back the tooth structure. So although, for example, Ivoclar don't say that you should use, for example, lithium disilicate or a lucite reinforced ceramics of about 1 millimeter, they recommend 1.5, 2 millimeter, which is a problem. We have been using that for when I have enamel as a substrate, no problem at all. You can use 0.3, 0.5. But when you have less than 1 millimeter, and when you have a lot of dentin exposure, you are at risk. I understand that the loads are actual, I understand that, but over time, this interface get old, and sometimes on the long term you can have problems. But the important here, usually you have not only all the periphery you have an enamel, which increases a lot the adhesive interface there. So I try to make as minimally invasive as possible, just to provide and to level the surface in order to have a uniform thickness of ceramic. This is quite important, to have a uniform thickness. Okay, you can have a thin porcelain, but you have to make it uniform in order not to distribute the concentration of stress. And I think, to my mind, Stefan, just my point of view is, I don't have so many problems with the lower anteriors, because the lower anteriors, the forces are pretty much compressive, instead of, for example, in the upper anteriors. The upper anteriors, you have much more tension force and shear force. On the lowers, you have much more compressive stresses. So over time, doing that for more than almost 15 years, I have very low failures with lower veneers, because all the stresses are compressive. So usually you have an island of enamel, and I understand that you have erosion, that you have attrition on the incisal edge, but you have enamel on the interproximal surface, on the lingual surface, and also on the buccal. So I think, just a minute, I think that making crowns for lower anteriors is too aggressive, because the amount of the structure will reduce a lot, and it's very easy for you to evolve to endodontics after that. And if you have endodontics in the lower anteriors, it's almost it's almost the end. Just my point of view.
No, can I add something, Irina?
Absolutely.
So thank you, Marcello, for bringing these additional things. In that cases, I lost all the lingual enamel. So if I have no more enamel, I didn't want to go for a sandwich in the lower part, because for me it didn't make sense. And then first, if on one side I have to lengthen than more than 2 millimeters, I have some dentin exposure on buccal and no more enamel in lingual, then if I make the calculation on the table, I have no more, let's say, other option, but this is not my favorite option. But on the other side, for the upper, as you said, for me, it's not at all a problem to have a lot of dentin exposure in the palatal area, which is, let's say, the most common destruction, because while there is the protrusion, there is a compression of the palatal restoration. So, of course, I have just a very thin enamel belt on the proximal and maybe lingual, but it's not at all a problem as long as it is a pressure. And then for my buccal veneers, of course, it will be solicited only for 5% of my cycle, but I will have the buccal enamel that I try to keep. And then, of course, for me, it makes sense to go for this sandwich approach, which is less minimally invasive comparing to a full crown. And even if you have 1,000 of, you have the V-prep and things like this, you have many options in the anterior part. But I have to say that it's you don't have 1,000 Ks where you can make that kind of very easy insertion of a full monolithic or not monolithic restoration. And for many cases, especially when you have a kind of triangular shape, unfortunately, if you want to insert a full restoration, at a certain time, you have too much undercut in order to offer you the possibility to insert. So this is why the partial banded restoration is a must for that kind of cases. I mean, whatever is the severity, I always try to go for that option, except for the extreme too much perio involved because of the crown lengthening and things like this.
Yeah, I totally agree with the two of you. We're currently coming up with the 6-year results retrospective study on the cases treated with the 3-step concept developed and published by Francesca. And I have to say that the outcomes of these patients after 6 years are just amazing, excellent. So in the next weeks, I guess the papers should be on the road. And you will see
Yeah.
pretty soon. Now,
These are great papers, and I fully agree with what Marcelo and Steph says from a functional perspective. Everything they said, I'm 100% with that. But another aspect is how to bond it, because that's the most critical part.
yes.
So one of my strongest beliefs is that as long as we have an enamel chamfer, like Marcelo mentioned, that is a green light. And because of the time limitation, I couldn't explain it well, that in the failures we had previously, as a confession, we were not using this beautiful technique from Pascal and Didier, the IDS, the immediate dentin sealing. So if we can get advantage of that, as soon as we prep, when the dentin is fresh, preferably without removing the smear layer, using the sixth generation self-etching primers, isolating this area, and then keeping it as it is will give extra strength for our bonding. And I mean, Pascal is showing cases like bonding to this much of, to that much of porcelain who's been in the mouth for years. I'm not brave to try it in my private practice, but in most of we take care of that. I think the success rates are pretty high.
Yeah, I think you've raised a very, very good topic. It's very also a topic of many of the questions that we have here. It's the adhesive cementation. And it's the adhesive cementation of the final restoration, but it's also the protocols that you have for the provisionals and their cementation. So maybe Galip, that you just raised the topic, could you just tell us also how do you do your provisional phase, and how do you, in the end select which cements to use where?
Okay, well, to start with, let's say we had dentin exposure. My first step would be to do an IDS, immediate dentin sealing, using self-etching primers, because my job is not with enamel. They are not good enough to etch the enamel, so I'm limiting it in. And if I use a composite with high field particles like Optibond FL, I'm well off. I can polymerize it, even if I will have some oxygen inhibited layer on top. The thickness of the Optibond FL will be sufficient to get the polymerization in the bottom. So then when it comes to my provisionals, I leave it like this. When it comes to my provisionals, I use a different technique. What I do is I take the same silicone tray that I placed my APT, because the patient already loved it. So I cut it horizontally, a millimeter coronal to the tip of the papillas. So when I place it in the mouth, I can see all the soft tissues, but the incisal edges. So I fill it up with my composite, place it in the mouth, clean the excess, 100% self-cured or light cured. With the polymerization shrinkage, it stays there like rock hard. It's impossible to take it out. And then the rest I do with my freehand carving composites, finish my provisionals. If that will stay more than a week, I apply gentle adhesive to prevent micro leakage. So this is the provisional part. For the end, when the patient comes, if I don't see any other dentin exposure, accidental, I just go with the fourth generation, acid etch, prime, bond, and finish it. So basically, this is my procedures. I still stick into the fourth generations for bonding the veneers, and that's it. If for some reason I have still dentin exposure at that stage, before getting into anything, I apply the same rules of immediate dentin sealing. First, I will take care of that opening. And once it's there, again, I go with my fourth generation, full etch, total etch, and rinse and the rest.
Thank you very much. This was very clear, and I think a very easy and clear protocol. Super. So would you do the same in the posterior region then, Stefan?
Me, I love standardization in the bonding protocol because it's highly sensitive, first. Second, my protocol is the same for, let's say, posterior or anterior for all my bonding protocols, the same material, and I'm using an individual dam. But just before, let's say, speaking about the final let's say bonding protocol, I would like just to speak a little bit about the temporary, because which is crucial, and I think the tricky part when we speak about full mouth rehabilitation with that kind of very thin occlusal restoration. So I will go a little bit in another direction, let's say, not because I'm against my dear Pascal, which is a kind of a mentor for many of us, but just going back to my clinical, let's say, reality and situation. When you go for the IDS, because you have some dentin exposure, okay, great, you have a beautiful protection. And then came the, let's say, the step of using, as Galip explained, I use my 3D printed template as I use for my full mock-up. I just inject my Luxatem, for example, and I just place a bit of adhesive on the surface of the tooth, just not for the, let's say, the marginal integrity, but just to have a little bit more retention. So I flask directly my, my template, and I'm waiting, let's say, for the curing. If, let's say, if I am doing an IDS before, how can you remove your temporary without headache? Just, I would like to know, because when you go for a full mouth rehabilitation, if you need to use a burr to remove the temporary, then you lose all the benefit of removing something and placing this very delicate and very high fit thin restoration. So when I asked this question also to our friend from Netherlands, I forgot his name, Marco Gressling, and because he is also a very good ambassador for the IDS. And I said, explain me. And he told me, yes, we are always using this because we have a fantastic bond strength result at the end. And I say, okay, this I know. But just before, how can you deal with the temporary? You say, we place some glycerina to avoid what you said. I say, yes, but if I use glycerina, how do you want my temporary to long last for 2 or 3 weeks? So basically, I never use the IDS because my patients are, if they are coming with a kind of very high sensitivity, this means that I have some deep cavity somehow, somewhere, and I will make a kind of first restoration prior to my prep in order to, as exactly Marcello explained, you need to have a kind of good homogeneity for the thickness of your restoration, especially if you have a proximal decay or things like this. So first, you made your direct restoration. It can be with a bulk composite, with a dual core composite, a core buildup, whatever you want, just to make a dentin substitute able to align the geometry of the restoration. And after that, on top of that, I will just make my temporary with a spot of adhesive. Maybe, scientifically speaking, it is less politically correct, but if you want me to tell you the truth, this is how I am dealing without headache in my everyday practice. So for the final restoration, then I will sandblast every time. Of course, if there is some dentin, I won't sandblast the dentin because I don't see the interest, just to clean already that kind of dirty layer. And then I will go for etching and adhesive in the, let's say, the basic protocol.
Okay, excellent. Also very clear. I think it's interesting to see how anterior and posterior regions are really difficult and different also. You have to really switch your minds. So what do you do if you want to augment the vertical dimension at the same time? And now you want the patient 3 months to wear this adaptation to really get relaxed.
Yeah. This is for Marcello or for myself?
Yeah, it could be for Marcello.
Ah, okay, sorry.
Before he falls asleep, like it's too warm in Brazil at the moment.
First of all, for making that kind of static and functional provisional, also I cement my provisionals with actually the cement, a resin cement that I have without paying too much attention for the adhesion. Actually, I make just one spot here and there, like a spot etch, just to maintain the provisional in place. and usually it lasts because we have more actual loads. But I have a point, because I think there are different, we have different approaches for inlays and onlays and overlays. The provisionals, usually they are a nightmare for the dentist because they don't keep in place. That's why I think in these situations, the immediate dentin sealing are very useful. Actually, this approach, it comes from Nakabayashi in 1982, and then Stefan Poe and Paul Scherer brought to Europe in 97, and Pascal Magnier actually spread out the idea, but it's the same, and now actually is the same and using with just different adhesives, like Nakabayashi started with Panavia or Clearfield at that time, and nowadays they are using like the Kerr, I forgot the adhesive, like the Optibond. So I think that for the posteriors, onlays and inlays, because usually it get lost, I think it's easy, and also it's nice for you to make the dentin sealing. The problem with the provisional, you have to clean it up, not only the surface, but also the soft tissue everywhere. Because if you don't clean it very well with Profi paste, and also after that you apply some Vaseline or some cocoa butter, the provisional will get there, will stick, and you cannot remove. Also, the impression material will stick to the immediate dentin sealing. It's a nightmare. That's why I like to make only on the onlays and overlays. For crowns, it's a nightmare because you cannot control all the axial surfaces of the crown. It's a nightmare. You can make it, but you should like rubber dent, put a rubber dent to control all the moisture 360 degrees. I think it's a nightmare.
Mm.
For cementations, Irene, final cementation, the anteriors and posterior, I think it's different because in the posteriors you have a lot of dentin exposed. My cement of choice over time is Panavia, and nowadays with Panavia V5, because you have a self-conditioner adhesive primer, and it lasts over time. For the anteriors, as the amount of dentin is too reduced, as Galip mentioned, and Galip, you don't remember me, but I was in the audience the first time you went to Brazil. I was there looking at your beautiful presentation. After the presentation, I went to you and I did the same question for you if you used to make immediate dentin sealing. So for the anterior, I think you don't need to do, because sometimes you have like islands of dentin exposed here and there. I think it's more than enough to use a 4th generation adhesive for that. I've been using like Variolink for almost 15 years. Before that, I used to use heated composite, but I don't see any kind of advantage since you have a very tiny interface, very small interface. For me, it doesn't make any difference.
Yeah. Really, really great, I would say, concepts and recommendations for all the audience and also for myself. You know, it's really great to see and hear how you're doing things and to adjust what we are doing accordingly. I would love to continue discussing with you the rest of the day. We have 40 questions, but I think we have to stop at one point. It's 7 o'clock in Geneva, so I guess what is Brazil? It's like 1 o'clock in the afternoon right now, or is it, Marcelo, what time is it?
Yes, 2 o'clock. My wife is waiting for me for having lunch.
Okay, go have lunch. We will have dinner. Thank you very much, Galip. Thank you very much, Marcelo and Stefan. It was really great. And I think the last word is with Mr. Hase Junior.
Yes, I just wanted to say thank you again, all of you, for doing this, for joining us. Irena, you did a wonderful job keeping these 3 alpha males in check. I enjoyed every... So thank you, Galip. Thank you, Marcello. Thank you, Stefan. And thank you, Irena, for taking the time off, for being with our audience, with our customers, teaching them and keeping the world together a little bit in these crazy times.
And thanks to the audience and all the great questions and interactions. Have a nice day.
Thank you, Irina. Thank you very much. You were great. Thank you, Galip. A big hug. Stefan, hug.
Yeah.
Thank you.
Christian, bye-bye. Thank you.
Thank you, all of you. Take care of you. Bye-bye.
Ciao.